Hi, I'm Tanzeen Bukhari. I apologize for not being there. Just had a baby 10 days ago. I'm a clinical engineer by profession and I graduated from Imperial College London. I worked in Pakistan ever since with various INGOs such as the World Bank, DFID, WHO, and a few private setups here in Pakistan. Um, so, COVID-19 highlighted the critical role of medical equipment and the importance of availability and access of oxygen supplies. In Pakistan, WHO supported a baseline survey to access the availability of different oxygen and associated essential equipment in order to prioritize and relocate equipment to define and forecast actual needs and make informed decisions. I was hired as a technical specialist to facilitate and validate and consolidate the data. This data will facilitate the government to gauge its preparedness in terms of readiness for the availability of safe and functional medical equipment for a second or third surge of COVID-19 or any other respiratory epidemic or pandemic. Uh, So the key objectives of the assignment were to conduct the assessment, create a guideline on the intervention required for oxygen supply roadmap and biomedical maintenance systems, and quantify a national standard for selected biomedical equipment, and work towards a national rationale. The methodology used was that WHO regional office and the country office liaison with the National Health Services and Regulation and Coordination Department for data collection. The original survey by WHO was modified, keeping in view the level of the expertise and the technical staff available in the health facilities. A guideline was created to facilitate the data collectors. Health facilities were identified from all provinces. We have 5 provinces in Pakistan. Ideally, these facilities included a few tertiary healthcare facilities, some DHQs, and some private healthcare facilities. Focal persons were engaged from all provinces of Pakistan to give ownership of the data to the respective government. We were very careful with our methodology, but still a lot of challenges and limitations were faced. Health service delivery is a provincial subject in Pakistan. The provincial governments were very skeptical in sharing their data because of politics and a lot of issues. A lot of persuasion took place, and which resulted in delays. This was mainly due to unavailability of focal persons and the overall bureaucratic process that exists in the government. WHO provincial offices, on the other hand, were also short on manpower, so we could not engage everyone. There were other unforeseen circumstances, such as start of a polio campaign, and some provinces were hit by floods, so that did affect our data collection. Lastly, although we did modify it to facilitate the availability of the technical persons available in health facilities, but still a lot of data was incomplete, and I or my team had to personally contact the health facilities to verify the data. In the end, we did manage to get a sizable data from the 5 provinces. There were 32 facilities from Punjab, which is the biggest province in Pakistan, 10 facilities from Sindh, 7 from Balochistan, and 48 from KPK. 7 were from Azad Jammu Kashmir and GB. The key identifiers were that VIE and PSA were unavailable in most of the health facilities. In 4 of the provinces, only Punjab had proper medical gas pipeline in most of the DHQ hospitals. A lot of disparity was seen in the availability of equipment across similar type of health facilities throughout the provinces. Non-functionality of equipment was also quite high throughout the provinces, except, again, Punjab. Even the number that was provided was not the true depiction of the actual non-functionality of the equipment. This was mainly because the non-functionality data was not properly filled in the data collection, and the main reasons were unavailability of staff, technical training wasn't available, there weren't proper maintenance setups. Hence, these numbers were expected to be quite high, but it did identify the main reasons that had to be addressed in one way or another. Once we had the data, what we did was we selected 5 national best practices. So these national best practices, 2 of them were our JCI accredited institutions in Pakistan. The other are quite good institutions. So we took 2 from Sindh, 2 from Punjab, and 1 from KPK. There weren't any hospitals from Balochistan or AJK-NGB which could be taken as national best practices. 3 identifiers were identified: critical bed to ventilator ratio, total bed to monitor ratio, and total bed to pulse oximeter ratio. A national ratio was also defined or was analyzed according to the data, and a recommendation was given accordingly. This slide shows the overall summary, which I've already highlighted: unavailability of medical gas pipeline, maintenance management system, and equipment unavailability. Through the survey, we have come to the conclusion that a national policy is the need of the hour, and that should be made with the government, with government and WHO country offices assistance, and strategies should be implemented for oxygen supply systems and biomedical maintenance system. In terms of oxygen systems, medical gas pipeline should ideally be installed at least in all DHQ and above level facilities, so DHQ and tertiary level facilities. PSA should be available for all far-fetched areas where liquid oxygen is not available. Moreover, production of oxygen should not be given only to the private organization, but should be done on provincial and divisional level to give ownership of and availability of this essential medicine. Assessment of oxygen supply systems for provision of appropriate technology and procurement should be based on the demand. Establishment of medical gas facilities should be done for monitoring and devising operational guidelines and ensuring training of the staff dealing with these medical gases. For biomedical maintenance management system, equipment to critical bed ratio, which we found was not same for all the similar level of facilities, should be same nationwide. An essential facility-wise medical equipment list is very important. Regulatory bodies such as the Drug Regulatory of Pakistan should be engaged to ensure maintenance management system is in place in healthcare facilities as well, because that is very essential for patient safety. Training of technical staff is very important. There should be proper schools, and training of master trainers with these national best practices health facilities should also be there. A facility-wise guideline should be devised on how to maintain or manage equipment, and a national repository could be created for basic troubleshooting, which could be used throughout healthcare facilities and for training purposes as well. Maintenance budget is not designated for medical equipment, and that is the main reason for non-functionality. So if healthcare facility is a provincial subject, then a designated maintenance budget should be present for all provinces. Lastly, there should be a national advisory board to manage the risk and adverse effect of the medical equipment, and to ensure that the essential equipment is functional and safe from patient use. Thank you so much.
Wow, that was an absolutely fantastic presentation from Tanzeen. Really interesting to see not only the inventory of equipment and health technologies for COVID, but also of the health technology management systems that are required to support them, and a real roadmap for their country in Pakistan.